And I would be pleased, and I'm very happy that one of my friends from UK, Professor Mamas is going to speak for this, and I must thank him wholeheartedly. Mamas, my friend, thank you for accepting our invitation to be speaker here, though this honor lies with the chairperson, but I could not resist myself saying this on screen. It's so good to see you in this COVID times. I wish that we had it for the real conference, but for the time being, we'll be more than happy to have you virtually, and I look forward to have you physically in the next CARDIOCON whenever we do that, Mamas.
Thank you.
Pleasure. So I invite Professor Ajay Mahajan, another good friend and senior of mine, I very well respected professor, Professor Sanghvi from Jodhpur, Dr. Rashesh Puthiwala as chairperson, Dr. Alok Shinde, Dr. Kushal Pujara, and Dr. Amit Patil as moderators. Over to chair, Dr. Mahajan.
Good evening. Today is a very, very interesting discussion. So first of all, I congratulate Dr. Manas for accepting this invitation. And we want to hear from him. He is basically a cardiologist from London. He is current appointments. He is director of Center for the Prognosis Research, Institute of Primary Care and Health Sciences, Professor Interventional Cardiology, Keele University, cardiologist in Royal Stoke Hospital. He is honorary professor for Population Health, University of Manchester. He is adjunct professor and research, Jefferson University, Philadelphia. He is a visiting professor, Professor Case, Western University, Heart and Vascular Center, USA. So his international and national position in responsibility in various forums in European Society of Cardiology, in European Association of PCI, in NHR, HTA interventional procedure panels, and heart research UK medical review panels. So without wasting any time, I'm just asking Dr. Manas to contribute on this particular controversy. What is his take on this particular scenario?
So thank you for inviting me. It's great to see so many friends in this meeting. It's a real honour, and it's a real honour to be amongst such a esteemed panel. So thank you, Mr. Chairman, for your kind words. And it's an honour to debate against my colleague as well, Dr. Shah. So over the next 7 minutes, 8 minutes, I'm going to really talk about how the radial route is the preferred modality in this case that we're debating. And really, the frame of this talk is that it will offer no opinions. It will be just data, because without data, you're just another person with an opinion. That's a great saying from Edward Deming. And it doesn't really matter what I say or what Dr. Bhupesh Shah says. I mean, in God we trust, but everybody else must bring data. And what really matters, it's not what we say, it's what the data says. And so really the important considerations for this debate are going to be 4 questions. Number 1, are outcomes associated with primary PCI better through the radial approach? Number 2, is the radial approach feasible in patients with cardiogenic shock such as this? Number 3, are PCI outcomes better through the radial approach in cardiogenic shock? And number 4, should you change your access site because you need a temporary wire? So I'm going to answer all these 4 questions, and I hope that after answering, you will see that radial is the only approach to consider here. So number 1, are outcomes better with primary PCI through the radial approach? Well, yes, if you look at the sum total of published literature, so that's 17 randomized controlled trial in over 12,000 patients, we see a 30% reduction in mortality, a 40% reduction in major bleeding, a 60% reduction in vascular complications. Now, the next speaker may talk about the Safari study, and this was the randomized controlled trial comparing radial versus femoral. The important point to remember from this trial was that it was terminated due to futility. It took 7 years to run this trial, and the event rate was very low because it was a highly selected trial. And so they stopped it prematurely because it was futile. And therefore it lacks statistical power to tell us anything. So you cannot use Safari trial to tell you anything. Its power was only 17% to detect significant differences between the radial and femoral arm. When you add it to the whole body of literature, there is still an overwhelming benefit of radial. Now, he may say that we should use vessel plugs to improve outcomes with femoral. And the fact is that the radial approach is associated with better outcomes compared to femoral with plug devices. And this is a paper that we published with my good friend, Sanjay Chu. We also have best practice guidelines. So these are not opinions, these are best practice guidelines that are based on 17 randomized controlled trials, observational studies from over 1.5 million patients that says radial access should be used as a class 1A indication in patients with STEMI, such as this case. So second point, is the radial approach feasible in patients such as this with cardiogenic shock, where the blood pressure is 70 or 80? Well, this is some work that I published several years ago, where we looked at access site practice in the United Kingdom in 7,000 cardiogenic shock AMI patients. And you can see that at this time of 6-7 years ago, to about 1/3 of cardiogenic shock cases were undertaken through the radial approach. In 2019, the data is closer to 60% of cardiogenic shock cases are undertaken radially. The third point, are PCI outcomes better through the radial approach in cardiogenic shock? And this is the sum total published literature. 8 trials, 8,000 patients, going radially reduces the mortality by 45%. The final question, should your access site change because you need a temporary wire? Well, there are no studies of access site in PCI with temporary wire in the setting of STEMI. There is no data. But my argument should be, should having a temporary wire mean that you have to go femoral? No, there is absolutely no logical reason to this. And the other point to bear in mind is this patient's predicted risk of major bleeding complications. So I entered this patient that we're discussing through the cath PCI major bleeding risk calculator. And remember, this is a bleeding risk score derived from the United States, which includes many Asian patients, that was validated in over 1 million patients. And this shows that this patient's major bleeding complications are 16%. That means that if you have 6 patients like the one we're discussing, one of them will have a major bleed. This is some data that we published a few years ago in 500,000 patients looking at the benefits of radial according to major bleeding. And this is where our patient lies. I've just shown you he has a 1 in 6 risk of major bleeding. And so you can see that going radial in this patient would be associated with better mortality outcomes. This is not personal opinion. This is data from 500,000 patients. You may argue, well, how about if we use a balloon pump in this patient? Well, you shouldn't be using a balloon pump in this patient. The IABP shock trial was negative. So I think in summary, I want to make 5 points. Number 1, the data unequivocally show that in primary PCI, which is what this case shows, you should go radial. This is a class 1A indication and as well supported by 17 randomized controlled trials. Number 2, in cases of shock, which this patient has, radial is better. This is data derived from 8 studies from over 8,000 patients. Number 3, this patient is at major risk of bleeding complications. Using the cath PCI risk stratification tool that was developed in 1 million patients, this patient has a 16% chance, that's a 1 in 6 chance of developing major bleeding complications. So he's at high risk of bleeding. The benefit of radial relates to bleeding risk. In this case, his outcomes will be much better going through radial. If you can't palpate the radial, use ultrasound. This debate should not be about whether it's easier if we're going to access the femoral vein with a pacing wire to just go femorally. It should be what is better for the patient. And undoubtedly, what is better for the patient in data that I have shown you is going radial. Thank you.
Thank you, sir, for the excellent and crisp presentation. Now I invite Dr. Bhupesh Shah, sir, for his presentation.
And because I had on the high because I have to deliver off from the highway. So share my screen.
Yes, sir, you can share your screen.
Audible? Come on. Hello.
Yes, sir, you're audible.
The said, yeah, so it was very nice presentation by Dr. Mamas, and all of us know that we are using the rail. But sometimes, when the patient come the emergency with bradycardia and hypotension, so we can't sometimes be so much stubborn that I want to use radial, because when we have it takes time to reach the coronary vessels too, because there is always lag between femoral artery and the radial artery in the emergency situation, about 2 to 4 minutes. And this was the patient, but however, we can see that the same kind of the patients, I mean, usually this kind of the patients, they are not studied widely in the setting of the cardiogenic shock when the high PCR clock is there. So that the type of the patients, they are usually excluded from the majority of trials. That the manage the patient high risk coronary syndrome. And we see that even
I think we have a poor internet connection on. Sir, please unmute. Dr. Bhupesh, sir, please unmute.
So you must have got a notification on your screen. Unmute yourself. His internet connection is really poor, so
this was the Safari STMI trial, which already said, but we see that about the options they have included in the trial of last year for more than 6 years, but still can see that the and with HIV is there have to love femoral which utilize this product, which is the modality that is oral versus radial.
so we lost him because of internet.
Dr. Bhupesh, you can shut down your camera because your bandwidth is low. You can just share the screen.
Okay, sure.
We are losing your internet connection.
Okay,
We're not able to see your slide. So you can just shut your camera and just share the screen.
When such consistent, when everyone, sometimes we are stuck up with the various radial loops. And sometimes arterial use area, which also make our life difficult in this emergency situation. Radial activities, their bifurcation, person, torture, 20%. Other miscellaneous which person come of the femoral lab. This is
Bhupesh, we can't see your screen because of
patient
probably low internet
in
connectivity. You can just stop sharing and just speak out. Probably that will be better. Maybe the bandwidth is low.
Okay. So, to the fact that when radial access is achieved, better terms in vascular complication, but there is non-inferiority as far as femoral access, which is concerned. Sometime in the patient where we need intra-arterial implantation of the pump, the central aortic pressure, which comes little bit high, 10 to 20 high when we are taking with the femoral compared to the radial. And these are the various requirements. So we need, when we are dealing with the radial, there are access failure in 3 to 5% of the cases. We have to shift to the femoral, radial spasm, radial loop, subclavian, brachiocephalotortuosity, lack of guiding support. Sometimes dye utilization is very high with the radial perforation, hematomas, compartment syndrome. So everything which is there is even with radial. And this is the chart. We know that every minute is very important when we are dealing with the evolution. We can't time in the radial are struggling for the radial spasm and the loop if likely to happen in the duration. And the most important thing which
we are not able to hear Dr.
Bhupesh. So taking such patients.
Chairpersons, if you can have your viewpoints, Dr. Ajay Mahajan, Dr. Sangvi.
Sir, the most important thing about this particular debate is that always the operator has to find out his comfort at that particular scenario. If the patient is in cardiogenic shock and if the patient is requiring a temporary pacemaker, already patient is sometimes elderly patients or some clues for getting some problems with the radial, particularly if we want to exchange the catheters or you want to do some complex procedure with the 7th French, then it is better to go with the femoral. But still, if the operator is very, very comfortable and very high volume operator, then one can take every patient on radial. And as far as the temporary pacemaker job is concerned, that can be taken by anesthetist through jugular route, and then there is no need to touch the groin of the patient. So these are my views. So I am always open for both. But young patients, I always prefer radial. But elderly patients where predictability as far as the radial is concerned is sometimes not that much comfortable because of accelerated atherosclerosis and some loops and other things. So elderly more than 65 or more than 70 years old with some compromised hemodynamics at the time of index procedure, I prefer femoral. But these are my views. But if one is radialist, one can go with that, and the temporary pacemaker job can be done through the jugular route. These are my views.
Dr. Bhupesh, are you there with us? Can you hear us? Dr. Bhupesh?
Yes, can you hear me, Kamal?
Yeah, your voice is breaking, but we can hear you now. Please go ahead. Please go ahead.
So I think these are the different between. So this is very Dr. Mujenes said. First, we know it as well as because in emergency situation, sometimes we need support everything. Sometimes it turns out to be left main intervention. We need to testing. Very important we through femoral, and in this emergency situation, every minute counts. I think femoral is quite better. That is what I think. Thank you very much.
Dr. Mamas, I would like to have your comments on Safari STMI trial.
Yes, so I mean, this is a trial that many people talk about. I think there's major issues with it, and we're about to have a paper published in CCI where we tear it apart. Really, the main problem with this is that number one, it doesn't really tell us anything. It was a trial that was discontinued prematurely because it was underpowered. Therefore, you cannot look into the results of it. It's an underpowered trial, that the outcomes are meaningless. It's not powered to tell us anything. Digging deeper though, this is a very low risk population. If you look at the average age and the 30-day mortality, it's incredibly low. And actually, it's half as low as any other primary PCI trial that's been undertaken. And so it really is showing that this is a selected trial. And the second thing is that the crossover rates were incredibly high, given that it was a low risk population. It was close to 10%. So you do wonder what the competency of the operators undertaking this study were.
Am I audible?
We have had some cases where the radial was taken, not of course in acute situations, but radial has been punctured and then it's been closed by the manual compression, and now the patient needs to be taken again for a re-intervention. You can't palpate the higher radials. Would you recommend to go for a simultaneous or the same sitting ulnar puncture? Because people now talk about intraosseous supply being they're good enough not to be compromised by dual puncture technique. There are some papers where people have done dual puncture in the same sitting. So would, in that scenario, still you would be averse to use a femoral?
I mean, so in the last 3 years, the UK publishes how many cases that we do radially and femorally. I've done 1 case femorally in the last 3 years. So if I can't get into the radial, I'll go left radial. It's very rare that I have to go ulnar. There is data that it is safe. So Sasko Kedev has published a very nice series of close to 1,000 patients. I do feel slightly uncomfortable having to go ulnar if you failed radials. If you mess up the ulnar, then that may compromise hand function, although he doesn't show that. So I would switch over to left radial. And with balloon tracking that people like Tejas Patel from Ahmedabad have published and reported first, I think the spasm and things like that really aren't a problem. And the final comment to say is that it's really the elderly patients that we should be going radial, because actually they're the ones that have the most to benefit. It's not the young 20-year-old or 30-year-old or 40-year-old, it's the elderly women with the small radials. They're the ones with the highest risk of bleeding complications. They're the ones that have most benefit.
Dr. Sangvi, Dr. Alok, Dr. Kushal, Dr. Amit Patil, your comments, please.
I think radial route is
My
very
question to Dr.
established.
Mamas. I just want to ask Dr. Mamas, if the most of the time in India, what we get is a pharmaco-invasive approach. The patient got thrombolytic therapy, and
Yes.
then the patient gets shifted for the intervention with conduction disturbances, complete heart block. And then if the patient is already received some tenecteplase or some thrombolytic therapy, then radial is the best approach. But what is the take on your side as far as these type of patients are concerned in UK?
Okay, so interesting question. And we've actually published a paper on this in JACC Interventions a few years ago, looking at those for rescue PCI, so those that have had thrombolysis and then have a rescue PCI. And again, radial has much better outcomes, and if anything, even better outcomes than in primary PCI. The reason being, as you quite rightly say, these patients have very high risk of bleeding complications. It's very rare in the UK that we do thrombolysis. So this year, the data that I've looked at in 2020, less than 100 patients in the whole country had thrombolysis. I can't remember the last time I gave thrombolysis. I don't even think I'd be able to know what the doses were or how to do it.
Just one question. In this COVID era, still you are going with the primary PCI without...
Yes. So we've published our primary PCI experience in heart earlier this year. And again, we haven't noticed an increase in thrombolysis. So it's less than 1% in the country.
Another thing, if the scenario is that if there is some radial loop and you have taken the puncture and there is a radial loop and then you want to shift from right to left radial, does it significantly increases the door to balloon time?
Well,
or
I mean,
you
it
prepare
will,
both the things
slightly,
together?
it will slightly, but then there was a great paper by Robert Ye from Harvard, one of my friends, and what he looked at was how much time you'd have to delay the procedure by to lose the benefit of radial, and the answer was over 50 minutes. And so just switching right to left does not add 50 minutes to your time. It may increase it by 5 minutes, even 10 minutes. You would still have a benefit from going radial.
Another one question. Another important thing, what we always follow when we are going with the primary PCI with radial,
Sir, the time
we
is up.
always... Hello?
Yeah, we can finish the discussion. Go ahead.
Okay. If we are going with the primary PCI with radial, we always think of offhand which artery is involved, just seeing the clinical scenario, and we directly put the guiding catheter and do that procedure, and then exchange and do the remaining diagnostic procedure, because changing from diagnostic to guiding might induce some spasm, and then we might get some more problem while going for a PCI procedure with the second catheter, with the guiding catheter. Rather, can we go upfront guiding catheter, what we are following here in India at our center?
Yes, I think you're all experienced interventionalists on this call, and I agree with that approach. I mean, that's exactly what I do. I often, if it's an anterior, I'll just go with an EBU catheter straight up, do the procedure, then take the shot of the right at the end, and vice versa.
Yes.
Any other quick comments from any of the chairpersons or moderators?
I think both are right at their own place, and both works in different area, different country. So I think I would just consider as a localized expertise, and as per the center, time is very crucial. You have to think of bleeding risk as well, and decide the approach rather than just thinking that this is right and this is wrong. That's my conclusion at this stage.
Hopefully next year we'll be able to discuss these things in person.
Nice discussion. Thank you.
Thank you.
Okay. If there are no other comments, we'll end up with this session. Thank you all. It was an interesting session. We'll move